Okay, it has started, and let everyone know they're being included. Okay. All right, everybody. I just started the recording for our lunchtime series from the Home Care Alliance of Massachusetts, a free series we put on each month. Take an hour out of your day to go over a business topic or best practices. And today we're going to talk through EVV from our friends at eCaring. You can still give it another couple minutes while people come on, but if you guys want to tell Justin, who's in the southern part of the country, how did you handle the snowstorm? What best practices did you put in place?
Are we talking Justin Hanslick?
Hey, Justin. Oh yeah, share your screen or share your slides when you're ready. Okay. I don't know how the storm will impact EVV specifically, but I do know we had a lot of members who had their caregivers arrive the day before and stay overnight. And then, of course, they have to bill the families for that extended time or eat it. And others just move the appointment a day ahead or a day before if it was something that could be managed. But we had videos of people going out with snowmobiles to see patients. Yeah, and just climbing over these huge snowbanks. Yeah, I don't know how it'll. Everybody has an emergency preparedness policy that includes snow. That's not even outside the realm of normal. So we do have other ones that are kind of not as common. I live on the northernmost part of the state, and there's a nuclear power plant on the ocean, so we have meltdown procedures. But probably don't need that everywhere, hopefully. But what about you, Teresa? How did you guys handle the storm?
So we had a blizzard here on the Cape, so it was rough. Our emergency plan got put into place. And then we were out of power. We were out of power, close, some of us up to 4 days. So our answer is get a generator. Yep. Our offices work off of generators. And really the challenge with EVV is we had some patients who went to stay with family members.
Oh, sure, yeah.
So then then you have to manually adjust for the geographic location, because maybe their family member had a generator. So right. It was a challenge, but I'm happy to say that every single drop of snow is melted away right now. So
yeah. Yep.
Hey, we see a lot of emails from the Home Care Association of Florida about hurricane planning. They get the other type of extreme weather there. I can remember back to, this would have been 2017, before I got into the technology side of home care and was running a home care agency here in Atlanta. We had about 5 inches of snow one weekend, which is devastating to a metropolitan area this large that does not have the equipment, because we don't regularly get that type of weather. I spent a lot of time, I had a 4-wheel drive SUV, and I spent a lot of time driving around and picking caregivers up and taking them to their shifts as needed to make sure that people could still be seen. And we had some of those situations as well, where I think we had a caregiver who ended up staying like 3 days at the clients because it just wasn't safe for them to leave after they got there.
All right. So welcome, everybody. It is now about 12 o'clock. Justin is sharing his screen. I'm just going to let in the last few people. I want to apologize to everyone on the call. Thank you for taking the time to check your email before we started. I apologize. The Zoom account was occupied, and I had to pivot last minute. So I don't like doing it, but I really appreciate you understanding and helping us out with that. We were just chatting as we got going here about our emergency responses to the blizzard a couple weeks ago, and a little bit how that has impacted and challenges for EVV. Probably challenges that people expected. Not 100% sure the software is ready for New England weather, but you know what? Who is, right? So anyway, thank you again for coming to this Alliance hour for, or actually probably won't even be that long, right? I think, Justin, you said like probably half of that. But anyway, thank you for coming to the Lunch and Learn. Justin, if you want to take it away.
Sure. Thank you, everyone. And thanks, Leslie, for the introduction. I guess we'll get to see a lot of you in person here in about a month and a half at the New England Home Care Conference. So we'll be there. Make sure you stop by the booth if you make it up and say hi. It'd be great to meet everyone in person. I already saw one question here in the chat. I'll try to keep it open as well while I'm sharing. So if I ignore you though, or I'm not ignoring you, I probably just didn't see it as I'm talking through this. eCaring is a home care agency management platform. We're also an alternate EVV vendor, approved in I think 17 states now, but we did get our start in Massachusetts. So I'm going to go ahead and we'll get started here with some intros. Mike Trigilio may be a familiar name to many of you. He is the CEO of eCaring. He's also the CEO of Houseworks, in serving the greater New England area now, and all the way down to Pennsylvania, and Associated Home Care. So he started eCaring about 4 years ago. It was not the current platform that we have today. It was they acquired the home care IT platform, and then started rebuilding that business, and then built a new platform, which is eCaring. So we launched this platform 2 years ago. So you'll have myself on here as well. Justin Woods, who's on the call as well, is our head of sales. And then Linda Paluski, who's not on the call today, but I wanted to include her in this, as she's our director of client services. So Justin, Linda, and myself have all been in home care for at least 8 years. Some of us longer than that. Linda and I both have experience before getting into the technology space, operating home care agencies ourselves. And then we all three met working together at ClearCare prior to the WellSky acquisition, and then through the WellSky acquisition. And then we all kind of brought ourselves back together here at eCaring over the last 2.5 years. So, kind of if we look overall, like what is eCaring, to answer that question, it's to bring all your care tools together in a single place. So our mission is to simplify home care. We want to allow agencies to apply a formulaic approach to their most common actions and tasks to provide consistent and predictable outcomes. So there are certain things that you do every day 100 times. We want to make those as templatized, so to speak, as it makes sense to, so that you can kind of have guardrails in place. The goal is, we want to prevent the unexpected or bad things from happening, which lead to all of the manual efforts and the exceptions. And in this case, for the topic of today's call, EVV issues. So, we're working to try and overcome the historical challenges that agencies have around match criteria, who can work with which client, where is this caregiver willing to travel and work, what types of services are they able to provide or credentialed to apply. We see, historically speaking, that information is well known at agencies. The problem is it usually lives in the head of your coordinators or in certain people, and when they leave, that knowledge leaves. It doesn't oftentimes end up in the system. And our goal is to try and make that as easy as possible for that information to all live in a single place, and for the system to then drive your workflows like scheduling, and everything else. So it is an end-to-end platform, and that we support, the client management, staff management, management of your payers, your services, which I'll talk more about when we talk a little bit about eCaring later in the call. Scheduling, of course, care delivery through our EVV compliant mobile apps and our IVR telephony system, verification, billing, payroll, and then obviously communications as well. So, but just wanted to introduce you a little bit about eCaring, so you kind of understand where our perspective is on this and what our role we all play in this. But we'll move on here and we'll talk about the Massachusetts EVV situation. We're all in this boat together. It's funny. I used AI to create that image yesterday, and it made me laugh because it created a couple of different images. One of them was a highway, and it was showing like the different phases of EVV, which we'll talk about here in a second. And I thought it was hilarious because it was specific about Massachusetts. So on the highway, one of the lanes was a toll road, which I thought was great. But if you looked close at the image that it created, all of the lanes went in one direction. So I'm guessing there was going to be a lot of head-on collisions, and that's kind of what you get these days, I think, if you try to use AI for certain things. But I see there's more people here, so I'm going to just admit them, Leslie, if that's okay.
Yes, thank you.
Perfect. Yeah.
Responding to their emails as they come in.
They keep popping up here, so I'll try and keep admitting them as we go along here. So sorry.
Sorry.
I don't know if that was a question.
Put
Okay.
myself on mute.
Oh, no problem. So I think as hopefully we're all aware at this point, Massachusetts adopted a 3-phase approach to implementing EVV. So phase 1 was adoption and participation. This is what started back in the fall of 2024, trying to get agencies registered with SAN data. If they're using an alternate EVV vendor, getting them declared and registered, then they start providing credentials to the alternate EVV vendors. It was really just about that first step, getting people on board and participating. And then you had in end of January 2025, so just over 13 months ago now, is when they started accepting the EVV data from the various systems and alternate EVV providers. So it was really all about adoption and participation. They wanted to get agencies signed up. They wanted to get agencies to participate, get agencies to start submitting data. They weren't really doing anything with it there at the time. The objective is just to get everyone moving in that direction. Phase 2, which is where we're at right now, is the visit submissions with compliance monitoring. So the key objective here is just building momentum through adoption, soft failures, visibility, and reporting. So I think everybody is, whether you're participating in programs with Mass Health members, which do cross over to other payers like CCA and organizations like that, or with the ASAP serviced programs or age programs, then you have some different.
For a bit, okay?
You have some
have to listen to all this.
Different requirements there. I'm going to just click mute all. And then that way, if somebody joins off mute, it'll mute them, and then they can take themselves off mute if they have something they want to talk about. So that's the current phase that we're at right now. And then phase 3 will be claim edits and claim matching. So the key objective here is going to be the compliance and really the meaningful impact to providers, to the state, to the programs, and ultimately to the clients as well. So I will talk through a little bit of each of these here, but I really want to focus on what phase 2 is right now. So where we're at. Mass Health actually began their compliance monitoring back in April of last year. We know that they've been sending out letters to providers, updating them on their compliance percentage since late summer, early fall. And their current compliance rate as of today is at 40% of auto-verified visits. What that means is that the caregiver is clocking themselves in and out of the visit using one of the EVV compliant methods, so an IVR system or a mobile app. The agency then is reporting that visit data with all of the EVV mandated fields to SAN data without making any manual edits to the times or the methods. So that's when you hear about a clean or an auto-approved visit in SANdata. The big picture is that today, at least, because they're not checking certain things and there's no tasks or anything else like that required in Massachusetts yet. Today, a manual visit is generally defined as a visit where the client and staff information is correct and accepted by SANdata and matched. The visit contains all of the EVV mandated fields for the clock in and clock out method and type, and doesn't have any sort of manual edits or overrides to it. Mass Health has had this implemented since early, we'll just call it, summer of last year. AGE, ASAP, EOHHS, they began their what they call compliance monitoring on December 1st of last year. So the way it's working right now with these programs is they monitored from December 1st to December 31st. Reporting periods then started on January 15th for the month of December. Going forward, though, there won't be a monthly reporting period. They will all be quarterly. And their current compliance rate is they're looking for 30% of auto-approved or verified visits. I want to talk a little bit more about this before moving on to phase 3, just so people understand a little bit more technically about how this happens. So when visits are completed in an alternate EVV system, that visit is then transmitted to SANdata. There are some guidelines around this. SANdata is looking to have visits sent over in as near of real time as possible. In our system, we send them once they reach the complete status. We go ahead and queue them up and submit them. There are some alternate methods that SANdata has worked with certain providers on, or certain alternate systems to do like a flat file or something like that that aren't using the API that may send data at different frequencies. The way it works, though, is so we send the original visit. The original visit has all of the EVV information in it and the client and caregiver information as well. That client or caregiver information does have to be sent in advance. So when you get a new client or a new caregiver, your system should be sending that over to SANdata to go ahead and create them within the SANdata portal. Or if it's a client, we can't create them. They actually have to match to a record, which you probably see a lot of rejections about that in Massachusetts right now because there's a lot of complexity around who has a Medicaid ID, who doesn't have a Medicaid ID. This person's an ASAP member, but they actually do have a ASAP client, but they do have a Medicaid ID, so I can't use their ASAP ID. There is candidly a lot of it's very messy around that right now. That has mostly to do, though, with not that the information doesn't exist, but the right people aren't sharing the right information. And then SANdata has a process for updating visits. And this is where these visits get flagged then as exceptions, or they lose their auto approval. So if your agency has to make a manual edit to the clock in or clock out, or they need to adjust the clock in time or the clock out time for any reason, the most common one we see is the caregiver forgets to clock out and leaves the visit, and so the agency then has to clock them out. When that happens, it immediately creates an exception. So that's one of your visits then that's going to count against you meeting these auto-approved metrics. Those visits get sent, updated and resent to SANdata. They include a separate payload, and that's kind of how SANdata tracks all of that, is through their data model. So that's where we're at right now. Agencies are all being monitored. I do hear there's not a lot of communication coming back. I don't know that I've had any of our customers tell us that they've actually gotten this report that was supposed to start on January 15th for the month of December from ASAPs. But we're working off the documentation of what the process is supposed to be. Hopefully they are reaching out to agencies now. I would imagine because the ASAPs actually do have their own set of requirements from EOHHS and AGE that they have to meet towards the total percentage of their provider network that are actually submitting EVV visits. So while providers are measured based on the compliance rate of their visits, ASAPs are being measured by the state on the participation in the EVV program of their providers. And I think right now they're required to have, I believe it's 70% participation across their provider network. So I would imagine that right now the ASAPs are probably much more focused on making sure that they're reaching that 70% threshold of provider participation than they are working out to the, providers who are submitting EVV data, but maybe below the 30% auto approval rate. Phase 3, and this is the important one, and it's coming very quickly. And this is where I think there's probably a lot of concern, validly, and questions around what is this all going to look like. And that's the phase 3 is the claim edits and matching. And this is where it kind of moves from process. We're working through the process, and we're really driving to the impact aspect of it. So Mass Health is scheduled to start for the period beginning April 1st of this year. Their compliance rate goes up to 50%. And I'll talk a little bit more about this in a minute, because according to their documentation, I'll say it that way, Mass Health and EOHHS age do not calculate the compliance rate for providers in the same fashion. I do not know if they are going to align around to that, but according to their documentation that they've released so far, they actually use different methods to calculate compliance. And I'll talk about that in more detail. The ASAP managed services are expected to start soft edits by May of 2026, with hard edits implemented by July or August. What is the distinction here for our purposes is that a soft edit means that they should not deny any claim, but they should notify you as the provider of all exceptions or claims that would have been denied. Okay. A hard edit, which is what they say is coming in July or August, literally on the same document. In one place it says August, in the other place it says July. I think it has to do with the measurement period versus when they plan to actually enforce the measurement period. But July or August, if they implement hard edits, that means that you could actually have a denial where they would deny a claim where there is no EVV data to back it up. So if we kind of go back here and look at the two different compliance measurement methods. So Mass Health has a compliance rate of 50% for this phase beginning April 1st. Mass Health is measuring compliance according to their documentation based out of all of the visits submitted to EVV, not compared to the visits that you bill for. Again, that's according to their documentation. I'm guessing they may revisit that. But effectively, the way it's written right now is that if you submit 100 visits to EVV and 50 of them are auto-approved, you are compliant. If for some reason you billed for 200 visits, that wouldn't put you out of compliance according to the way they have written this right now, because they're only measuring against submitted EVV visits. I would imagine their assumption, though, is you're submitting all of your visits, and they probably are going to rephrase this to make that more clear. Age has specifically called out in their communication that 90% of the provider's claims have to have a matching EVV visit. It doesn't actually say anything about auto approval. It just says that 90% of all claims need to have a matching EVV visit. So I'm going to move on to the next slide here, because there's probably a lot of questions and confusions around that now. and I'm not trying to create any. I'm just reviewing the documentation that has been provided publicly and is publicly posted on the website. And these are just their differences in how things have been documented and communicated. So I think one of the most important things that you can do is focus on these areas right now, which is control what you can control, which is EVV adoption. Your agency is really only able to control that. I think, again, if we go back to my little silly canoe slide, we are all in this together. I think the state is learning, the ASAPs are learning, the Mass Health Organization is learning, CCA is learning. Everybody is learning about what EVV looks like right now in Massachusetts. Obviously, you know, going back 5 years, there's been like a stop and a start and a stop, and then a period of break. I think it became very clear they weren't going to allow it to be pushed out any further, which is why, you know, they're moving, and now they're moving even more quickly than they'd originally communicated. So the best thing you can do is to control what you can, which is EVV adoption. And I know that there's a lot of pushback from caregivers, and understandably so. It fundamentally changes the way that they have worked for years. But just know that you can be in a position of confidence here, like that they're not going to go to another agency in Massachusetts and not encounter this. For the most part, it would have to be somebody that's doing, you know, all private pay services and is not working with any of the state programs, which doesn't seem to be terribly common in the state of Massachusetts because of the robust programs that are offered. So stay focused on what you can control, which is the EVV adoption aspect. Focus on retraining your schedulers on processes to reduce the number of visits that get impacted by manual edits or manual punches. For so many years, it really hasn't mattered what you've done with a visit after, you know, it's completed or in the process of completing it, because those edits and changes weren't tracked and reported anywhere. They are tracked and reported now to be EVV compliant. And so it's really important for your teams and your coordinators to know, as they're working through the billing and the payroll process and everything else, that they're very aware. Obviously, edits still need to be made, and if they need to be made to support, you know, proper billing and proper payroll, that's great. But be very careful and aware of changes that you're making. I'm always surprised how often we see, like, people will change something on a visit and then they'll just change it back to what it originally was, and it's like, hey, you just created an exception for nothing. And honestly, they were just playing around and not really understanding what they were doing. So it's important that you work with your team, your alternate EVV provider. If it's us, reach out to us. We're happy to walk through this with your team, that you really understand how edits that are made to visits impact EVV and overall that compliance percentage. Understand and look at how you're being measured. You can log into SANdata. You should log into SANdata regularly. You can see how all of the visit from your alternate EVV system is being reported into SANdata. You can see all of the visits. You can see the clients. You can see the location information. All of the information coming from your alternate EVV system that goes into SANdata is readily visible to you using the account that you registered with SANdata initially. There is a compliance report that you can run in there that actually will take you through and show you whether visits were what they call auto-approved or auto-verified or not. So you can monitor that yourself. You don't have to wait for reports to come out from ASAPs. The agencies that we work with that took that on and are regularly monitoring that are generally doing much better with compliance than the ones who are not. So I recommend everybody, look, it's your data, it's your account. Your alternate EVV vendor does not have access to that account, meaning I can write data into SANdata and then I can update the data that I wrote into SANdata, but I cannot log into your SANdata account and view all your information within SANdata. Only the organization can do that through the credentials that they were given. From a overall client and services perspective, I would heavily recommend, highly recommend that you focus on utilization of the authorized services that the client or the members that you serve have. If we kind of take a step back and we look at, okay, this is going to move into the claim edits phase here pretty quick. That means that all of these organizations are going to have much more access and insight and reporting here now, showing exactly what utilization is compared to what was authorized. So if you have clients that are regularly declining services or canceling services, the risk, and I'm saying this just based off of experience watching this roll out in other states and everything else, the risk that they run there is their services are going to kind of be what I would say right-sized. If they've underutilized their authorized services consistently, they're probably going to see their authorized services reduced to what's actually being used. The state's going to look at this and say, okay, well, here's what they actually need. Now, the good news is I know there's still a wait list in Massachusetts, and there's still people trying to get on services, and there's always budget constraints and things like that. What it should pave is not a loss in total hours, but it should pave the way to being able to serve more clients as they move through this. So pay close attention to the utilization. You want to maximize the utilization, obviously, if the customers need it. And if you have customers that are regularly not utilizing their hours, you probably should be aware, like there's probably going to be a time over the next 12 to 18 months where their authorized services probably become what I would call right-sized. The other thing, and if we go back to my previous slide where you have mass health and age, they've got different compliance percentages, and then they've got also different methods. Currently, the way it's written, they have different methods for calculating that compliance rate. One of the best things you can do is just advocate for consistent standards across all payers and programs. And I would add to that then as well, interoperability and access to data. If we go back to the beginning when this all started rolling out, people who are serving ASAPs all of a sudden needed to know what payer program their clients had been approved under. And that's not a data point that the ASAPs have communicated to providers in Massachusetts for several years now, to my understanding. And the data is all there. It's all readily available, but they weren't communicating it. They weren't sharing it. Providing interoperability and access to that data is critical for the information to move and for you not to run into issues of matching clients when you submit them and things like that. I'm going to take a pause here, and then I would like to share a few slides with how e-caring is built and can help with this. But Leslie, if I take a pause here, I know I've seen some messages pop up in the chat. I don't know if there's any questions that
There's only two
okay.
that you might want to address. Do you want to read them? Rebecca has said, are the compliance percentages meant to be by agency level or payer specific? So a compliance percent for all EVV required payers the agency has, or each payer individually?
So that's a great question. It's a little bit unique in the way, the way the ASAPs operate in Massachusetts is fairly unique compared to the way those types of organizations operate in other states. Ultimately, at the end of the day, the ASAPs are governed by EOHHS or AGE, and you're going to be measured against your compliance at that level as far as we're aware. Mass Health has, again, their compliance formula as shared today is slightly different than AGE's. So you would have a different compliance rate there if you're working with both Mass Health managed members and AGE managed members. I don't know, Rebecca, if I actually answered your question explicitly, because I don't know that there is a very clear answer to it right now.
We provide, we're credentialed with Mass Health standards. We provide home health visits and services via Mass Health, but we also are credentialed with several managed Medicaid payers as well that also require EVV. And we received a notice from one of those managed Medicaid payers that we were out of compliance. But when I run our data in SanData, and you would compile everything with Mass Health Standard, we are within the compliance percentage. We had one client under that one plan, and so they only looked at, it was like a 6-visit total. So the compliance percentage was skewed.
Got it.
Because that one client didn't have compliant visits.
Okay, so that's
that
really
was interesting.
Yeah, so, and is this, I'm going to throw out the most common one that I see because it creates a lot of issues with even matching clients, which is probably part of maybe Carrie's question below, which is like CCA. So I know for a lot of our customers, they never had, CCA doesn't give them the actual state Medicaid ID for the clients. They bill under the CCA ID, so that's the ID that they've always tracked. And then when EVV rolled out, all of a sudden, they're not able to actually submit their CCA members to EVV because they didn't have the Medicaid ID. So they had to go back to CCA, try and get the Medicaid ID and everything else. So what that would mean, I think, Rebecca, is that Mass Health is basically delegating the responsibility for compliance rates out to the individual managed care organizations, which is what they're doing with the ASAPs as well. My personal opinion is long-term, I think you're going to see that that's going to all get aggregated together into a single score. Because of exact situations like what you shared, which is I only have one client here with this payer versus I have 50 total Mass Health clients. So it doesn't really make a lot of sense to do it at an individual payer level like that. But I think right now they're probably treating those managed Medicaid plans like they are the ASAPs and saying, hey, you need to look at your compliance rate for your network of providers.
Okay, that makes sense.
Yep. And then Leslie, I'm going to mute you, Leslie. I think I'm getting a lot of feedback from you and I'm having a hard time hearing others. Okay. I don't know if that was just me. And then Carrie's question here. We're currently experiencing rejected visits in SanData due to client not found. Notably, other clients with the same payer and plan are being accepted without issue. Payer must submit the client information. We've also reached out to the ASAP. Okay. So, Carrie, you have a situation that we see as well, in that you're submitting typically using the ASAP billing ID, and most of your members get accepted, but some of them do not. Is that correct? Is Carrie?
Yes, that is correct.
Okay. So we've seen this as well, where we've seen two scenarios here. One, I'll start with this one because it's the least, it's not easy, but it's the least complex. Some members receiving service through ASAPs actually do have Medicaid IDs. The state's rule on this and the SanData guidelines are that if a person has a Medicaid ID, that must be the ID that's used to submit their EVV data, regardless of who their payer is. So I won't say it's rare, maybe 5-10% of the people that we see throughout our network of providers are seeing this with some of their ASAP members where, hey, this person actually does have a Mass Health Medicaid ID. And that is how their information was transmitted to the state. And you need that Medicaid ID to transmit their EVV data to the state. You will still continue to bill under their ASAP ID, I'll just call it that. for billing purposes, but the state is going to require a Medicaid ID for any of their EVV data to be accepted. So this is the same issue that we saw early on with CCA, where most CCA members they're delegated to CCA, which is a managed Medicaid plan, but they're actually Mass Health members and they all have Medicaid IDs. So you have to submit their EVV data to the state using their Medicaid ID, not their CCA ID. And this is where, if we kind of go back to my point around advocating for consistent standards and access to data, all of this data exists. The problem is, I think that the ASAPs and some of the payers were caught off guard, didn't really understand how all of this works, and they don't make it part of their normal workflow to provide you with all of the EVV mandated fields that you need to submit the EVV data. And this is where they can really support you in providing you with the data, the program codes for people, which tie back to the waiver that they're approved for services on through the state, the right ID that's going to exist at the state level. The other place that we see this with our customers, specifically with the ASAPs, is more of a business process situation. And honestly, it's one that I know I'm told is very confident, or not confident, but common, but would create a lot of concerns for me as a provider, which is the ASAPs will communicate directly to a provider that, here's a client, start services, and here's what you can do, and you start providing services for this person. And this goes back well before EVV, I'm told, because typically the failure would happen then when you go to bill them after providing services for a couple of weeks, and you bill them and that gets denied because they're still not in the system and everything else. Well, now there's just a whole nother layer to that, which is the ASAPs are communicating these new clients out. You begin services, and then not only can you not bill for it because they're maybe not in the system, which the ASAP can themselves immediately rectify, but also all of your EVV visits get rejected in the meantime. And this is really where things get kind of messy at the moment, because you may have, I think we've seen up to 45 days where someone is serving somebody on an EVV mandated service and every service is getting rejected. It's a new client, and it's all because the ASAP hasn't actually put the person into the system correctly yet, and then it hasn't been transmitted to SAN data. So this is a place where I think the ecosystem, all of the partners in Massachusetts are going to have to probably come together here pretty quick and say, hey, yeah, it's great. We got this person's services started as soon as possible. They were in need. That's awesome. We should keep doing that. But what can't lag behind by 30 or 45 days is actually getting this person in the system, because it would, because of the way you're going to be measured now, if you served this person for 30 days in March, and that's the end of the quarter, and all of your EVV visits are getting rejected because of that, because the person's not even in the system yet, it'll be really difficult to say how that could impact your overall performance and compliance in the state's eyes, because the person's not even in the system. And then you're going to try and bill for it and everything else. So I've seen both scenarios there. That one kind of caught me off guard. Ooh, you mean you don't even really have an authorization? No, they called. It's this is just how it works. It happens all the time. I think there's a big opportunity here again to advocate for consistent standards and processes across all of the stakeholders in this, to really make sure that the business processes that are commonplace today actually support the EVV processes, since that's how you're now going to be measured. The follow on to that, Carrie, is once they do end up in the system, you'll need to make sure that your EVV system is resending all of those visits. Well, is resending the client first so the client can match, and then resends all of those visits so that they get updated in the system. And that's kind of some of what I'll talk to you about here next. around how we've built out e-caring to try and support these workflows and resubmissions and things like that. So it's 12:42. I'm going to move really quick through this because I know you guys didn't sign up.
There is one hand raised. I want to get to it later. That's great. It's Tara.
I don't. Okay. Yeah, go ahead.
Hey, Justin.
Hey.
My name is Harut. We work for a home health agency that has Alt EVV through Home Care Home Base.
Okay.
Internally, we've closely monitored our compliance rate through SANdata. For the year, we're sitting at about 82%. However, we received a non-compliance notice last week, and when we connected with our Alt EVV vendor to sort of rectify and clarify what the issue is, we were told that our billing codes do not match the codes accepted for the payers by SANdata. As you can imagine, that's slightly difficult to manage given the codes that we're using are the codes that are on our contracts with these payer sources. And we're now being asked to update our billing codes, which you can't just go in and update because then you won't get paid because it's not on your contract.
Yep.
So we're sort of at a loss here because, again, how is it showing 82% compliance and we're sitting here all happy because we're well above the threshold, but at the same token getting a non-compliance letter for something that didn't flag, it didn't reject, it didn't create an exception, but we're being told that we have to change all of our billing codes, and it's common codes like a G0299, which is registered nurse visit.
Mm-hmm.
So we're sort of at a loss here.
I want to make sure I understand this because we've seen this on non-skilled services with CCA, but just for one service. So you're submitting under the current procedure codes or service code that you bill under.
Correct.
It is not causing a rejection in SANdata.
Correct.
So it's being accepted by SANdata. It's being accepted for billing. But you got a letter from your payer saying you're out of compliance. And
correct.
And your payer is saying you need to update the service code, or
our Alt EVV vendor.
Okay.
They ran an analysis to see what was causing the mismatch.
Mm-hmm.
And to their understanding, it was our billing codes.
It's possible. I see Rebecca mentioned this in the chat, like that there is maybe a missing modifier only. So there's been a scenario with CCA on the non-skilled services where I believe it's personal care services that agencies have always billed them under S5131. And then when the EVV guidelines came out, it says in the EVV guidelines that personal care services need to be submitted for EVV under T1019. If you submit a personal care service for CCA to SANdata as T1019, SANdata accepts it. If you bill under T1019, CCA will reject the billing because it's the wrong rate code for that actual service on their side. However, where this situation is slightly different than yours, and why maybe it's a modifier or maybe there's something else going on. If you submit under the billing code that you successfully get reimbursed for with this scenario. So if I bill under S5131, which is what it's always been billed at to CCA, and I submit that same service using the procedure code as S5131 to SANdata, SANdata will not accept it. It will reject it and saying that it's not a valid service for that client. So the fact that you're getting accepted billing and accepted EVV submissions is they're telling you that the resolution is the same, but your problem is entirely different. I don't see how you could get both accepted and it be a wrong service code unless it's potentially a modifier. And that is a really good call out, Rebecca. I can tell you that SANdata does not validate every single field in the payload against all other fields. They validate certain fields. So they'll validate and make sure that, hey, for this EVV payer ID and this EVV program code, is this procedure code a valid service or not? And then if the answer to that is yes, you could submit a client with the wrong EVV payer ID and SANDATA still accepts it. And we know this is true because CCA has 2 different EVV payer IDs. And CCA provides, in many cases, several of the same services regardless of the payer ID. And it does not matter which payer ID you use as long as the client has that service. So it could be some strange situation where you're kind of circumventing some of SANDATA's checks because they don't actually check the entire payload against all other fields. Or it could be something like a modifier. I haven't personally come across that. We primarily deal with non-skilled agencies. We do have some skilled services that are done in our system, but I haven't particularly seen that case where somebody is successfully submitting EVV and successfully billing and getting reimbursed and then being told that they're using the wrong service codes. That should not technically even be a possibility. So I would question the explanation like you are. But unfortunately, that is not a scenario that I have encountered yet.
That's awesome.
Yeah.
Okay. So, I mean, I guess, so in theory, it sounds like from what Rebecca mentioned, some other agencies are able to successfully submit the billing code GO299. So maybe it is a modifier issue, and if SANDATA is not cross-referencing everything, then it would still show us compliant, when in reality we're not.
Yeah, potentially, but you would also expect that if you were billing for a service that required a modifier, that it would get rejected. So it's certainly interesting that everything is getting approved. And so I actually have a lookup tool. So yes, GO299 can be, so GO299 is the, interesting. So there's, GO299 is direct skilled nursing services of an RN. And then GO299GT is for telehealth. And GO299UB is for complex care training and oversight by an RN. So I don't know offhand if your service description is direct skilled nursing services of an RN, then it should be submitted as GO299 without a modifier.
And that's what we do.
Yeah. And that's for almost all payers, it looks like. Mm-hmm. I have a spreadsheet that I can share. I actually took, and we're going to run out of time here to talk about our platform. That's fine. But we actually take for each state that, at least the states that have the complex matching, and we took all of the data out of the state guide and put it into a single document and combined all of the tables together so you can get all of the valid rows. And I'm happy to share this. So it allows you to look up by, service code or payer or the EVV payer ID and find all of the valid combinations for the different procedure codes and the payer programs.
That would be great to have.
Yeah. Yep. So I'd be happy to share that.
Okay. So would my best approach be to ask for a specific non-compliant case and make sure that all of these pieces match to what is acceptable?
Yeah, absolutely. Because you're getting a letter from the payer saying that you're not compliant.
Correct. And it's a very generic letter.
I mean, honestly, it could have been sent by mistake or something totally out of reference. Does it actually describe call
It doesn't
out
describe
on the letter?
anything. It just says that we ran it for a certain time frame. Your agency has a high mismatch of EVV visit record to claim rate in the Massachusetts EVV system. This means you're currently out of alignment with EVV requirements set forth by the Commonwealth of Massachusetts, and basically tells us to correct it and resubmit it.
So, are all of your visits? Do you have a high number of visits that are being billed for that don't have an EVV record at all yet?
Like,
or I should say, did you during that time period?
I did not. Are you talking for like the client not found error?
No, or you still have documentation that was visits that were being documented outside of an EVV system entirely, that you were billing for?
No, everything goes through our system and the alt EVV vendor. We did have the client not found issue in December, which was resolved. I took care of that. And then
do you know if the visits related to those clients were all resubmitted?
They were.
Okay.
Yep. Because we've gone through 2 warnings now. The first warning, we found out that it was the clients weren't found, and what we had to do was for clients that do not have straight Mass Health, we had to add to the claim the secondary Medicaid number. That resolved about 90% of the issues. For the other 10%, we had to reach out to the payer sources directly to load in the clients to SANdata. That was about a month-long process. That was not fun. But since then, our compliance numbers have gone up and improved, and we are no longer getting a client not found error. We're now just getting this out of nowhere.
Yeah, I would push for real specific examples of visits where they're saying there was not a match and you have the EVV records to back it up. I mean, it literally does require that sometimes, to drive down that deep into the system. So, and this in e-caring, we actually have this submission monitor. Most alternate tools have something similar to this, or I would expect them to at this point, where you can view in real time all of your, whether it's a caregiver that's sent over, a client that's sent over, or visits, with the approval status back from SANdata, or if there was a rejected visit, why it was rejected, and in our case we give quick links here so you can go directly to the place where you need to, whether it's a billing ID or a issue with that visit, to make those edits, and then our system, when those edits are made, automatically resubmits it to EVV, to hopefully then clear that. But I can't speak for for all systems. I think HomeCare Homebase, you still the actual clock in and clock out system is still CellTrack, I believe. I know it's deeply integrated, but so
I believe
yeah.
And we could get this off of the SANdata website, right?
The spreadsheet I was sharing is something we created ourselves using all of the documentation from the PDFs. I'm happy to share that spreadsheet out with people.
But for the rejections, I mean.
Oh, for the rejections, yes. If you can't see the rejections in your platform, like I said, we have a submission monitor as part of our application, so you can see it in real time. It comes right back across. Then you should be able to see it directly on those visits within SANdata.
Okay, yeah, because on our platform, everything is approved and has gone through successfully.
Yeah, then I would definitely check to make sure it shows that way in SANdata as well.
Okay.
They're a very experienced platform. I would be surprised if it didn't, but it's definitely worth checking there, because we've done, I think, 10 integrations now with SANdata in different states. They're all a little bit different. And usually the difference is like the error messages that they provide back. You have to parse them out differently and things like that. And then, when you move into states like Ohio and Indiana, where they're using the the EVV data to drive billing already, then you run into some different scenarios as well. So it's definitely worth logging directly into your SanData site to make sure the data appears the same way it does in your alternate EVV platform. But I would expect that it does.
Awesome. Thank you. And I apologize, everyone, for taking up your time.
No problem. All right. Well, I know we're at time,
great.
Leslie. So
yeah, no, these were great questions. I really appreciate an interactive webinar in the lunch hour. I really do. Thank you everybody for coming and staying. And I will respond with notes from this session, as well as the recording link and contact information for Justin, the slides and anything else he thinks might intrigue you. Thank you all, and if you are available next week on Thursday, we have a member meeting in the morning in Medford at Innovive and in the afternoon in Worcester at ARCA. So same material, both locations. I'll send a link to that information as well. Thanks, guys.
And then Leslie, will we get the spreadsheet in your email as well?
I think so, Justin.
Yeah.
If you send it to me, I can send it out.
Yeah, perfect.
Thank you.
I will send it out to you.
Cool. Thank you,
you.
everybody.
Take care.